Have you or someone you love been told you're losing bone density, and there's nothing you can do about it except maybe take some drugs? Maybe you've heard osteoporosis is inevitable with age, or that your only option is a medication that doesn't fix the root cause. If any of that sounds familiar, this episode is for you. Hey everybody, welcome back, and thank you for being here and joining me on the Dr. Terri Show today. Today, I have Dr. Doug Lucas joining me on the show. He also goes by Dr. Doug, and Dr. Doug is a former orthopedic surgeon turned functional health expert, and let me tell you, his journey is going to change the way you think about bone health. Dr. Doug's stories start where many do, and many of my colleagues that I have on this show, in the halls of conventional medicine. After a prestigious surgical training, including a fellowship at Stanford, he landed what many would consider a dream job. But inside the OR, something didn't sit right. His patients were showing up with the consequences of years of metabolic dysfunction, conditions that could have been prevented. You know, I'm all about root cause and prevention medicine, so this is just music to my ears. That was his breaking point, he's told me. He realized, I'm not really changing lives here. I'm patching up the damage that shouldn't have happened in the first place. So he left the operating room. He stepped away from a high-profile orthopedic career and leaned into something that many in his field still shy away from: functional, preventative, patient-centered medicine. Now, you may have been told osteoporosis is irreversible. You may have been told you're too old for hormone therapy, or that supplements are your best bet. Dr. Doug's work and clinical data challenge all of that. And in this conversation, we dig deep into how bone health isn't just about calcium or medications. It's about hormones, nutrition, exercise, stress, sleep, and yes, targeted supplementation when it's really needed. And that's really important to understand because so many people are taking all these supplements, they don't know what they're taking for. In this episode, we talk about how he discovered the power of health span versus lifespan, why resistance training and impact exercises are non-negotiables, especially when you're talking about bone and metabolic disease, the truth about GLP-1s as far as it impacts bones, hormone therapy, and bone loss, and why bisphosphonates, it's a big mouthful, that word, bisphosphonates may be giving you false hope, and what you can do, whether you're 35 or 75, to truly strengthen your bones. This isn't a doom and gloom osteoporosis episode. This is a hope-filled, science-backed call to action for everyone who's been told bone loss is just a part of aging. You'll also learn about his new book, The Osteoporosis Breakthrough, and his efforts to make cutting-edge care accessible by joining forces with LifeMD, an exciting new platform that will expand his reach across the country. Oh, and if you're wondering about supplements, like I said already, we tackle that too. Spoiler alert, they do matter, but they're the tip of the iceberg, not the foundation. So many people want to just supplement to fix all these problems. So whether you're a patient, a clinician, or somebody that's just curious about what it really means to thrive as you age, then this is a conversation that may just change your health trajectory and definitely your bones for the better. Hey, Dr. Doug, how are you doing? Thanks for being here.
Terri, great to see you. Thanks for having me.
Yeah. I've been really excited about this interview since you interviewed me, and I have so many questions about you. You were asking me questions last time. But one of the things that's super interesting to me about any person, and is their journey, is their story. And you actually have a story of how you went from conventional orthopedic medicine into more of a functional approach and kind of got out of that conventional thing. So just tell us your story. Let's start there.
Yeah, thanks. I appreciate you letting me tell it because I think it really shapes the conversation around bone health. So as you said, I was in the conventional medical model. So orthopedic surgeon by training, did all the usual stuff, the 5 years of residency, fellowship at Stanford, got the job that I wanted in a mountain town in Colorado, truly living the dream, as it were, in quotes. And what I found when I got into practice is that, yeah, I was happy with what we were doing in the OR, and operating room is a lot of fun. We can do some amazing stuff in the operating room. But what I found from a patient perspective is that I was really unhappy with not necessarily the outcomes. Surgery outcomes were good, but I wasn't really able to have the impact on my patients that I wanted, meaning that I felt like I was cleaning up the metabolic disease that we were just chasing, So people were coming in, and foot and ankle was my subspecialty. So people would come in with the tail end of years of metabolic dysfunction, either bad advice or bad choices from a nutrition or lifestyle perspective. And while I could make them different and we could do good surgeries, I really wasn't having a big impact on their life. So I have always been passionate about nutrition. I've always been interested in the power of exercise. And during that time, I started getting into this space of like, what does health span mean? And what does it mean to think of longevity and lifespan? And the more I learned about that, the more I realized I was kind of in the wrong place. So I took that next step of getting additional education because, let's face it, as an orthopedic surgeon, we're really good at that one thing, but not very broad. So I went through an entire additional fellowship, a lot of hormone training, and then I started a health optimization practice called Optimal Human Health. And that's where I entered into this space where I could actually start helping people to reverse osteoporosis and prevent osteoporosis through more of a comprehensive approach.
Yeah, and in many cases, even keeping them out of the OR, hopefully.
Yes, exactly. And that didn't work well as an orthopedic surgeon, as you can imagine. Yeah, your bosses don't like that.
Yeah, a cardiologist, functional cardiologist friend of mine, same thing. He's like, well, I'm kind of working myself out of a job, but doing the right things. So,
right.
So you really have had this focus, and you've written a book about it, but really shifting a lot of your focus to osteoporosis prevention. And tell us kind of the why about that, and what's got you so targeted and passionate about osteoporosis, and then your approach to it. I know hormones are a big part of it, but I really think you kind of look at more of a whole body synergistic approach. But let's talk about that.
Yeah, gosh. So osteoporosis, I really feel like I'm in the right place now because it just kept coming to me. My background in orthopedics led people with challenges with bone health to my front doorstep. Arguably, as an orthopedic surgeon, it sounds like I would know a lot about bone health. But the truth is, I knew a lot about fixing bones, about healing bones, but not a lot about bone metabolism, actually. But in the health span, longevity, health optimization, hormone space, you learn a lot about bone metabolism if you are looking in the right places. So our practice didn't start out all about bone health. It wasn't until, maybe about a year in where we had enough people that were coming to us having this problem that I felt like it was just being put in front of me and it really needed attention. Because when I look around at who is talking about bone health, yes, it's out there and people say bones are important, or at least in my world. But it's not loud enough, and there isn't a comprehensive approach out there to help people do it. So I thought, gosh, well, the program that we're doing should be good for bones. We just need to change the labs, maybe change the approach, change the way we look at hormones. And we started doing that. We started working with patients, kind of doing it more through the lens of health span. But what we saw was really remarkable, where we were seeing people that had pretty significant or severe osteoporosis, having their bone mineral density decline, stop, and then change course and then get better. And when we saw this start to happen, both in women who are on HRT, women who are not on HRT, and men, younger individuals, older individuals, we realized, gosh, the conversation around this is really not accurate. Some people will say it's reversible. Most doctors will say that it's not reversible. I think we need to absolutely change this whole thing. So that then became our mission. And the practice changes just happened as a result of that. That was just the impact of our message.
Yeah. So assuming your focus really began to focus on, yes, it can be reversible, correct? I mean, I've seen this in my own clinical practice.
Of course. Yeah. So those of us that are optimizing hormones, meaning using more than just the lowest effective dose for hot flashes and night sweats, those of us that are optimizing hormones are going to see reversal of osteoporosis in your patients if you're paying attention. Because it is, what we found is that it's one of the biggest levers we can pull. Now, you don't have to use HRT in order to do it, but what I've found is that hormones will exponentially expedite all the other work that we're doing.
Yeah, absolutely. Yeah. And so do you treat men also? So looking at hormones in men with osteo, because I'm reading some literature that's seeing more and more higher rates of osteoporosis in even men.
Yeah, I think it's a big unknown because right now, actually, the screening recommendations just changed so that men maybe should be screened at the age of 70, and that's about it, right? That's all of the lip service that they get for screening for bone health for men. The challenge I think we have, and you know this, and I'm sure you've talked about this openly, is that we're seeing more and more low testosterone in men, right?
Yeah.
So we're seeing an epidemic of low testosterone.
Even in young men.
Yeah, exactly. And this is the issue, because then as a result, we have less testosterone. Men don't make any appreciable amount of estrogen, so we need testosterone to produce estradiol, estradiol being one of the most powerful tools in the body for bones. So I think we actually have an epidemic of osteoporosis in men and even in young men, and we just don't know it. Now, fortunately, they have a higher starting point, so their bone mineral density is denser on average, right? They're less at risk for osteoporosis, and that's why the screening has changed. But if they're not reaching peak bone density in their early adulthood that is at an adequate level, and they don't have good testosterone or sex hormones, and you add on poor sleep, toxic environment, just keep layering things on.
Yeah.
I think we have a big problem that we just don't know because we're not screening.
We're not screening. Yeah, that's right. So just for our listeners that may not know, because I really haven't I've talked about hormones in other episodes about the impact on bone and the positive impact on bone building, but dig in a high level way of how hormones work to remodel bone and to build bone.
Yeah, so this was some of the the early work I did when we were trying to figure out what are the best tools, because everybody who has a product says it's the best thing, and every supplement says it's the best thing.
Yeah.
There isn't really a good hormone advocate out there, by the way. So there's nobody saying, yes, estradiol for bone.
I know.
It's because nobody's making money off of it. So we really had to dig into the research. And what really blew me away is that when you look at sex hormones, if you even go back to the literature, especially in young women, so we know, for women who are cycling, who have normal cycles or ovulating, they have this push-pull of estrogen and progesterone. And if that doesn't happen, if the ovulation goes away or the cycle gets dysfunctional, the luteal phase is short, you don't have adequate progesterone, you start to lose bone as a woman. And this is in women that have adequate estrogen. So we know that both estrogen play a big role, progesterone plays a big role, testosterone plays kind of an unknown role because it's not as well studied, more so in men, which I'll talk about. But when you get down to the cellular level, we see that estrogen can strongly impact the cells that break down bone, but it also has an impact on the cells that build bone. So it's actually working on both sides of the metabolic equation. Progesterone more on the bone building side. Testosterone probably more on the bone building side would be intuitive. And so all three of these sex hormones have a significant impact on bone metabolism. And if we look at osteoporosis as a dysfunction of bone metabolism, not just a T-score and a Dexa report, if we're looking at that bone metabolism, then these become very powerful tools. Of course, HRT, or estrogen specifically, is only FDA approved for the prevention of osteoporosis. But we know that if we're using it in women specifically, postmenopausal women, for other things, you see their bones get better. And then when you look in the literature, it is amazing how powerful it is for bone health.
Oh, yeah. So many studies. And, I teach when I'm teaching clinicians just on hormone therapy in general, there's some really great studies that we talk about. And I really hone in a lot on, and so does the rest of our teaching staff, on receptors. And if there is a receptor on a cell, there's an intention for that molecule in the cell. And when you understand all three bone cell types have androgen and estradiol receptors, it makes sense they have a role, right? So I love your approach with that, and thank you for that explanation, because I also have seen multiple. I can't even. It's not even. Can't even count them anymore. Women who have, and it takes about 2 years of really having their hormones optimized, from what I've seen, to start to see those scan results shift into more osteopenic and then eventually normal. So would you say the same? Yeah, that's right.
It's amazing. Yeah, it's really amazing. So we're getting results probably a little bit faster, but just because our patients
You're doing other things.
They're laser focused on it, right?
Yeah.
So they're nailing the diet, they're doing the resistance training, they're doing impact or
my dream patients.
Yeah, they're doing all the things because they came to us for a 12-month program. They paid a lot of money to really dig into the bone health thing. So yeah, we do see benefit, and for us, we actually ran the numbers on this with our last cohort that went through. And we saw about 60% on Dexa improvement at 12 months. And I don't think it's because the 40% aren't getting better. I just think 12 months is kind of the bare minimum on Dexa that you're going to see that improvement. Yeah.
Yeah. So generally, we talked about hormones, but what are some other things that you like to focus on with your patients? You've mentioned diet. You've mentioned some other things. I'm sure exercise has got to be a part of the equation. So what's your general approach?
Yeah, we frame it like this. Well, there's actually kind of two frameworks. So I'll start with the first one, which is, we call it the 4R method. I don't even need to go through it. But the summary is, you need to figure out why you're losing bone. Because again, if we think of osteoporosis as a bone metabolism problem, then why is your metabolism screwed up in the first place? Right? So why are you losing more bone than you're building? Figuring that out is a really critical part. So that's sort of in the investigation phase. And a lot of times it is hormone related, could be diet related, could be gut related, could be toxin related, could be a ton of things. But you got to figure out at least what some of those factors are. And then we go into building this program out. And the program, from a bone health perspective, really needs to be comprehensive to help most people. Now, you've seen it in your practice because you're optimizing hormones, and they probably had enough other things in line that their bones are going to start doing their thing. I know you practice an integrative, comprehensive approach anyway. But when we get into it, we start with the lifestyle pieces, and we have kind of four pillars that we talk about. So you already said them: nutrition, exercise, sleep is a really important one, especially postmenopausal women not on HRT. And then the stress piece, and the stress piece is the hardest one to manage, actually. So I'll kind of go back through each of those four. But in our framework, we have those lifestyle pieces, then hormone optimization, then custom supplementation. And then if we need to, we talk about maybe peptides or even bone drugs at that point. But the lifestyle pieces for bone health are interestingly controversial. So it gets us into this area around what is optimal protein, what are the optimal sources, what kind of exercise, does it need to be heavy? Like all of these kind of like touchy things if you get out on social media right now.
Yeah.
So our approach is to try to stay away from changing anybody's, ideology. I'm not here to change your values. But what I'm here to say is that the literature is very clear that we have to have the building blocks to build bone. Protein is the biggest building block in your bone by volume. So we need to eat adequate protein. Your gut has to then also be able to absorb it. And the absorption is a big piece. So for me and for most of our patients, animal products are the way to get adequate protein for the most part. Outside of that, as long as you're getting adequate calories and nutrients, I don't really care what you call your diet. I don't really care if you call it keto or Mediterranean. You can even do it through a plant-exclusive diet if you want. It's just harder. So that's like the big picture diet piece. The exercise piece is really interesting because a lot of, especially women, especially in our, the 60s, 70s age group, there's a group of women who've a lot of times never done any lifting. Ever, right? Never lifted a weight, only done, walking or other cardiovascular exercise. That's what they were, trained to believe was the right thing for them to do. And as a result, they have really low muscle mass. And they're afraid to start lifting weights because they also have osteoporosis. So now they're in kind of a tough starting point. But the good news here is that you can do resistance training from a very low starting point, and it actually doesn't take a lot to see tremendous gains. So it's never too late to start, and you just have to be very smart about it. And we have some approaches of how to help people who've never lifted a weight. How do you start lifting weights and doing resistance training? And that's important because the resistance training piece is critical. Now, resistance training by itself actually doesn't build bone, but we need to build muscle to also build bone. And then the third piece of that is impact. And this is the piece that I think is so misunderstood because if you look at studies that are well known as exercise studies for building bone, a lot of times they sort of snuck impact in there. And by impact, I mean like jumping off stuff. So we have to encourage our bones to actually grow more bone. And that takes impact. Resistance training alone is probably not enough for most people. So the impact or kind of simulated impact has to be in there. But again, this is where it gets really important to be cautious, because if you have osteoporosis and you've never lifted a weight and you're very sedentary and you start jumping off of stuff, I guarantee you're going to hurt yourself.
You're going to break something.
Yeah. So you really have to be careful and understand like how to do these things in a smart way to avoid injury, because it just takes too long to recover.
Yeah. Wow. That's great. You know what? You're right. I don't hear a lot about impact as far as what you're talking about. And that makes so much sense now. Kind of like, yeah, duh, that makes total sense. You said something that, I'm present to it because it's a big conversation. And that's with all the GLP-1 receptor agonists and the weight loss and the muscle loss. I bet if we started looking at these patients that are on it for a long time, that we probably would see some additional bone loss that goes along with that. So what are your thoughts on that?
So this is so poignant for me right now. So before we hit record, I was telling you that our company got acquired. So we're building our current platform on a bigger platform. So the company LifeMD bought our company.
I know.
Brought over my entire team so that we can build out our bone health program and also women's health on their platform. Super, super excited. So honored to be able to do that. But here's one of the conversations that really pushed us forward, which is they have tens of thousands of people on GLP-1s.
Yeah.
And they have the right language. You need to do resistance training. You need to get adequate protein. But unless you're really closely tracking, it's hard. I mean, I've used these drugs myself. You have to be very intentional. It is very difficult to get adequate protein and maintain muscle mass. And we already know what the impact is. If you look at the studies that a lot of people are citing, you're going to lose 40% or 60% of your weight through lean mass. Notice that they're not saying muscle, they're saying lean mass. That includes bone.
That's right.
Yeah, so we already know that it's happening, but we're not doing a great job of measuring it. We're also not screening people before they go on GLP-1s that they should be looking at their bone and knowing what their starting point is. So one of the things I want to do when we get this up and running is let's push the information out about how to screen for bone. Let's do it for our now tens of thousands of people, patient population in our own company. Let's see where people are and then just give them the right guidance. Not that you shouldn't use them, but you need to be smart about them. And if you are at a low bone starting point, then really consider how long you should be on that drug. And it probably isn't a lifetime drug for you.
I just did a podcast before this talking exactly about that thing. So what are your thoughts on, I know this is we're going on a different direction, but I think it's really important to talk about because the GLP-1s are so important and how clinicians are managing it. But as far as in our office, we have in-mode body composition scale that gives us free fat mass versus fat mass, and we get baselines and we track it. The salespeople say it's as accurate as a Dexa scan. Of course, I haven't seen the studies on that. Yeah. But what are your thoughts, on utilizing a technology like that to get some baseline information? Or do you recommend just everybody that is in a certain age or meets certain criteria get a baseline Dexa before they go on these GLP-1s? Or what are your thoughts on that?
Yeah, this is tough because this gets into the how do you screen the entire young adult population? And I don't know the answer to that because I can't, those numbers don't make sense to me, right?
Yeah.
But what I can say about this, I've actually looked at the bioimpedance scales. I actually did a video on InBody, so similar product, right? And I looked at the research that they had. This is all internal research validating it to Dexa, and it is pretty darn accurate. But you can also game Dexa too. I mean, I've kind of played with this with my own Dexas. I'm if you drink a liter of water before you go get a Dexa, you'll have really low body fat on Dexa. Cool. So, none of them are perfect, but having something that you can do on a regular basis is great. And so if it's your patients coming into your office and they have access to a high quality machine, that's awesome. I even think that home machines are not that bad, right? The home bioelectric impedance scales, especially if there's a handlebar attached to it, it's, they're not particularly accurate, but they're consistent, they're precise. And so what you want to do is just track that lean mass over time. Unfortunately, they're not great at bone, though. And the device that I looked at from InBody, it does report on bone, but we kind of looked into it and I couldn't make sense of what the numbers meant. So I don't think that's ready for prime time. I don't think those numbers are going to tell us much at this point. So I think you do need some kind of imaging modality for bone. Dexa is widely available. If you don't know what Dexa is as a listener, this is the thing that you use for the 65 and 70-year-old women and men to diagnose osteoporosis. It shows you bone density and it's okay and it's widely available. That's fine. It's not the best because it doesn't show you bone quality, but it's what we have access to. If people have access to it, I like the device called REMS. It's from the company Ecolite. They're out of Italy. It's just not widely available. And it's, insurance isn't going to cover it. But if you're young, insurance isn't going to cover it anyway. So you're talking a couple $100 either way. But I like REMS because it gives you both density as well as some form of quality through an ultrasound. So either of those would be a good thing to do. The challenge that we have as a country and really as a global population is, how do you do this for every 30-year-old
I know.
world?
Yeah, well, and even if we're just talking about it could become, and it should probably become, a regular screening tool just for general screening, not just maybe even in physicals or whatever. You said something important just now with Dexa scans about looking at bone quality, and that always leads me into the thought of the bisphosphonates. Everybody has questions still. I can't believe how many patients come to our office still on these medications. But I would love your thoughts on some of these drugs like Boniva, Fosamax, and whatever the more recent ones are called, and what it's actually doing to bone. It's giving good DEXA scan readings, but it's not really giving us good bone. So talk about that.
Yeah, these are so tough. Because if you look at the recommendations in the conventional system, the recommendation is if you have osteoporosis, and actually for some people, if you have osteopenia, meaning you don't even have osteoporosis, which is technically low bone mass now. But if you have low bone mass or osteoporosis, the recommendation is to use one of these drugs. The reason why they do that is because doctors in general are good people. They want to prevent fractures. They know that fractures are a bad deal. So they're going to use the tools that they have. And in our conventional medical system, we have drugs and we have surgery, and we don't have much else. Mm-hmm. So they're going to use the thing they have that does have evidence to support its use. It will make your DEXA look better, right? The challenge is that if we go back to the definition I said earlier, that osteoporosis is an imbalance of bone metabolism, we then understand that, okay, bone is a living tissue. It needs to break down. It needs to build up. And it's doing this constantly. When you take a bisphosphonate, like the ones that you mentioned, Prolia is a very popular one. It's the every 6-month injection.
Newer one.
These are called anti-resorptive drugs, and they slow down that bone resorption. So the bisphosphonates actually poison the cells that break down bone. Prolia actually just stops them from becoming cells at the precursor level. And so it just kills bone metabolism. It
doesn't really fix the root cause.
Right. Well, and so that's it. So there's a reason for that. I'll get to that. But if you look at the bone turnover markers, so these are these tests we use, CTX and P1NP in our practice, and we talk about them all the time. You can see what these cells are doing. Now, these tests aren't perfect, but they give you an idea of what's happening. For patients that are on Prolia, on the bisphosphonates, those bone turnover markers are absolutely suppressed. They're in the basement, which means that you're just not turning over bone. So here's what happens. You shut down bone metabolism. You're not breaking down bone. You're not really building bone anymore, but you're still calcifying the cartilage matrix that was already laid down. So this is why we see over the first, year to 3 years, or Prolia even longer, we see the density continue to get better. And we know that density is associated with fracture risk, and so your fracture risk goes down, and they do reduce fractures in studies. But the problem is you can't do that forever, because you need to break down bone in order to build bone. So if you're not breaking down bone, I use the analogy of like a road crew, right? So like if they're going to build a new bridge, they don't just put a new bridge on top of the old bridge, right? You have to take out the old bridge and then build a new bridge. Otherwise, the whole thing would fall apart. And that's what happens. The bone gets dense, but now it's brittle and dense. And so then you get these weird things like atypical femur fractures and these other kind of weird things that happen. And so it's not natural, and it's not a long-term approach. There's absolutely a time and a place for these drugs. So the cases I like to talk about are, a great example will be a woman who is on an estrogen blocking treatment for breast cancer, right? Mm-hmm. She's going to be, let's say she's going to be on this treatment for 5 years. She should get screened before she does this, in my opinion. And she has low bone density or osteoporosis out of the gate. I hear this all the time.
Yeah.
That's a great time to use one of these drugs because you have a limited window. You're going to be on this drug for your breast cancer for 5 years. You want to reduce the amount of bone that you're going to lose for 5 years. HRT is probably not a good option for you right now. So then let's use this drug temporarily to help prevent the bone loss. I think that's a perfect use case for these drugs. But you're right, it doesn't fix the underlying issue. And that question is not being asked because we don't practice root cause medicine in the conventional medical system. So then, people come off the drugs and guess what happens? They keep losing bone. right?
That's right.
So this is predictable, but there is just not a good long-term approach. And these are the women now that are in their especially 60s and 70s. They've been on bone drugs for 10 years, 15 years, and they're like, I don't know what to do now. And my doctor just is kind of like shrugging his shoulders because he doesn't know what to do either, right? It's not a long-term solution.
Right. Yeah, no, that's good. And I love your analogy about the bridge. I often use the analogy of, when you have a road with all these potholes, you wouldn't just go pour asphalt over that. You would need to dig up the old road and lay down new roads. Right. Kind of similar analogy. And thanks for that, because every time we kind of start having bone conversations, even in my office or even at trainings, doctors are always asking, clinicians are always asking about the bisphosphonates and their utility. And that was a great answer. So the other thing that you really focus on is, you talked about what's essential for bone health. And is it your opinion that HRT is optimizing hormones is an essential part of the bone health equation, or what are your thoughts on that?
Yeah, I hesitate to use the word essential. And the reason for that is because our average patient population right now is probably early 60s. So we deal a lot with women who are 10, 20, 30 years out from menopause, and a lot of them are afraid to start HRT. And we have the conversation, look, the newer literature shows that it's not risky, all those things. But we have women who will not, they're just not comfortable, or they have a lot of risk factors and they don't want to start HRT. So what we've seen in those patients is that they can improve their bone. So I don't necessarily think it's essential, but oh my gosh, it makes it so much easier. So the lifestyle pieces, all of it still works. It's just so much slower because the stimulus isn't there. If you add HRT, and especially if you start optimizing HRT, then all of a sudden everything just becomes exponentially stronger.
That's great. And you just touched on something about benefits versus risk. And there's still, unfortunately, a lot of controversies. And we both know most of it comes from the synthetic hormones with progestins primarily. Now the literature is coming out that even the synthetic estrogen products actually show benefit. It's the progestin that really was the problem. But I'd love to hear your thoughts on that, because always, you just said it, there's women that are confused. They've been told they can't, they shouldn't, I'm too old, etc. And let's dive into that a little bit. And what are your thoughts on this benefit versus risk and kind of balancing that approach out?
Yeah, I'll try to keep this short because this is something that just drives me absolutely nuts because I hear it all the time. In fact, I just got an email this morning. I was introduced to a woman who lives up in New York, and I'm super excited to get introduced to her because she's part of the ballet community, and I used to be part of the ballet community, and I want to educate them on bone health. So it was really great. Yeah. And then she says, oh, and by the way, I have osteoporosis, and I've been thinking about HRT, and it just kind of goes down this personal medical rabbit hole, which is fine. I love answering questions, but this is this scenario. She's 62, never started HRT, went through menopause at 50. She goes to her doctor. Her doctor says you're too old at 12 years out. And she's actually found other providers that have said, yes, no, I do think you should consider it, considering that you have osteoporosis at 62. But now she's fearful because of this perceived risk that she's going to have a cardiovascular event because she's 12 years out from menopause, right? And so, we were talking about how we could connect, and I said, I'm not taking patients right now. And I said, actually, look, if this is your only concern, I can do this in 30 seconds, right? Like, this is an easy one. So I haven't heard back from her yet. But this is the way that it goes. That scenario, over 10 years out from menopause, you're too old from the doctor, happens all the time. And this is an old dogma that needs to be corrected, because if you go back to, let's go back to early 2000s, the WHI, you just kind of led into it earlier, right? The WHI with Premarin, with Provera or MPA, the progestin and the synthetic estrogen, in that study, during that intervention, women over 10 years out from menopause, which was most of them, there was an increased risk of cardiovascular event. Okay, great. Now we have 20-year follow-up data of the same study, stratified by decade out from menopause. This was published in May of last year.
In the women who stayed on the medications.
Yes, exactly. In that study, if you were within 10 years of menopause, it's true. HRT in that form was protective of heart disease, which actually surprises me, but it was. But women 10 to 20 years out, while it was no longer protective of heart disease, here's the most important thing. It was not more risky than placebo.
Yep.
And this is what isn't understood is it riskier? I guess in theory, yes, but I can't go back in time to start you 10 years ago. All we can do is say, right now, compared to somebody who doesn't start, do you have more risk? And according to that study, in that population, the answer was no. Right. So then if that's true, why are we denying women care if they're like this lady that emailed me, 12 years out from menopause?
Yeah.
And also...
finish your thought and I'll say about it.
And this is what drives me nuts is the little bit I know about her is she has no strong family history. She has no personal history. She's tiny. She was a ballet dancer, right? Yeah. So she's very healthy otherwise. Like, what is her cardiovascular risk?
Right.
It's extremely low to begin with. So why would we be concerned that she's going to have an event when the studies also show that she shouldn't?
Right.
Right. So yeah, it just boggles my mind. Now, that being said, even if you go back to the early 2000s, go back to what the Menopause Society has said as guidelines and recommendations, it never said don't prescribe for women over 10 years after menopause. It said consider individual risk factors, which is what we still do. I do have some women in their 60s who have terrible risk factors for heart disease, and I don't start them on estrogen. We use other tools because, they've got crummy arteries, and I can't say that there's no risk there, right? So we still use individual risk factors, but to say that as a total group, anybody over 10 years out from menopause isn't a candidate for HRT is wow.
Yeah, and that's that most clinicians, unless this is your world to stay up to date on the hormone literature, wouldn't know that in 2017, that as a general guideline went out the window. This 10-year window of opportunity really only applied to the progestin arm of the WHI, not the estrogen only arm. So now the guidelines state, the North American Menopause Society 2017 guidelines state, it is no longer lowest dose for shortest amount of time. It is use an individualized approach, just like you just said, and evaluate risk factors and benefits of the therapy, because this poor woman that you just talked about that has no risk factors, not going on HRT now increases her risk exponentially for Alzheimer's disease and cardiovascular disease. The literature is there, and osteoporosis, of course, and colon cancer. So, you're avoiding hormones because of this perceived risk that doesn't exist, but the avoidance of hormones causes a risk for chronic disease that many clinicians aren't thinking of. And it makes me crazy as well. But, I can't hate on the clinicians that don't know. If you're not in this world, you have confirmation bias and it sticks in your mind how you learned it the first way.
Yeah. I mean, I so often I will hear the story and I ask, well, who did you go see? And usually it's an OBGYN. And I have no nothing against OBGYNs. I think that the field of obstetrics and gynecology is so overwhelming because there's so much information. I think that subspecialty should have been divided out into OB and GYN a long time ago. And hormones should be a separate specialty.
Right.
To think that you're going to go to an OBGYN that has to know everything about delivering babies and everything in women's health and do surgery.
Reproductive life.
Right? I mean, the entire thing, and then also be a hormone expert is very unrealistic. So I think that nobody wants hormones, especially now over the last 25 years. Like nobody wants it as a specialty for the most part. Mm-hmm. So it's left up to people like you and myself and everybody who has stepped out of the conventional medical model to sort of take this and say, oh, look, there's a lot of different ways to do this. We can individualize this and we can really have a great impact. But if you're in the conventional system, you are really lucky if you have a good provider on hormones.
Yeah, that's great. So I want to wrap up a little bit. I want you to talk a little bit about your book. And I want to talk a little bit about, now you just said you're not taking new patients, but maybe that's because you're in a transition.
Yeah,
I would like to talk a little bit about your practice. It's very unique. And I think you're just doing some amazing work in this space. So,
yeah. So let me take a step back and say, our practice is taking patients. I personally am not right now, just because we got a lot of things going on. We have such a great opportunity to truly change the landscape of healthcare. So I'm like, I'm super excited, and
I'm with you.
Yeah,
on
really
that.
busy, which is great. I love it. So the practice, so we kind of have two practices, which both got acquired and will now become part of LifeMD. Right now, those two practices are still taking patients. So one is called Optimal Human Health. That practice is very specific to bone health through the lens of healthspan, and it's a fantastic way to do it. The other practice is called PEM and Bioidentical. It's a hormone practice, very small, but it's a hormone optimization practice, the pathway that we set up. Right now, if you go to those websites, you could become a patient, but we are trying very hard to move this onto the LifeMD platform, because when we do that, we're going to have different offerings. They have insurance contracts and Medicare contracts. So we have a lot of potential to build some really, really cool programs through that company, through their platforms, using their tech. So I'm very, very excited to do that.
Expanding access.
Yeah, I just don't have a timeline on it. So that's the big unknown right now. So please get into our ecosystem, and then we'll continue to roll things out as we can. You mentioned the books. These are good starting points for anybody who is kind of new to this. If all of this is sort of just made your head explode, the books I wrote, one is called Osteoporosis Breakthrough, and that's very specific to bone health. And then the other one is called The Top 10 Reasons Why Your Hormones Are Failing You. And that's really about postmenopause hormone replacement and all the things that we've talked about today.
Yeah.
The other place where you could find great information is the YouTube channel, The Dr. Doug Show.
Mm-hmm.
The Dr. Doug Show is, the subtitle is Bones, Hormones, and Healthspan. So I think that kind of
and all of this will be linked in the show description for those of you listening. You don't have to frantically write it down. You can just go back to the show description. Before we wrap it up, is there anything else we didn't talk about that you're just dying to make sure we get on this show?
I think that the one big topic we didn't talk about that you're going to get lots of comments on is the supplement piece.
Yeah, let's do it.
Yeah, the supplement piece is, we don't have to talk about it a lot, because here's the thing. For a group of humans who don't want to take drugs to fix the problem, this is a group that really wants to supplement their way out of osteoporosis. Because if I ever post a video on supplements, just the views and the comments are through the roof, right? People love supplements. But here's the thing. Yeah, we use them. I think they're important, but that pyramid that I laid out, I didn't describe it as such, but our framework for creating programs is lifestyle, hormones, then supplements.
As a smaller tip of the pyramid.
It's at the tip of the pyramid because it's going to have less of an impact. And there are a bajillion products on the market. I'm not going to say which ones are great or not great, because everybody's supplement stack is different. All of our patients have a different stack. There's a lot of overlap, sure, but what you need is probably different than what your friend needs. It's different than what the person on the advertisement that you're seeing on Instagram needs. Right? So supplements really have to be customized, and that's all I wanted to say is that, we did not bring them up because we don't want to talk about them. There's a role, but it's got...
No, I'm glad you mentioned them. It's important because people do have so many questions, and it's not even just, there's a study that came out in 2019 and another one just even recently in 2022 that showed up to 90% now, 90% of the supplements over the counter on the market either don't have the ingredients listed on the label or are full of other fillers and toxins, because it's not a regulated industry. And I'm not all for a bunch of regulation, but some things should probably require some testing. I know. So you, like we, prefer more pharmaceutical grade nutraceuticals or, supplements that you can really only buy from a clinician, because those companies that make those do third-party test them for potency, purity. It has what it says it has in it. And I think that's the biggest thing. I see the same thing. New patients will come in with just a bag full of supplements, and I was like, what if I can take this down to about 4, And they're like, please, will you? Right. Because people are looking for ways to feel better. And you're right, people get caught in the social media loop. And Google, Facebook, and Instagram are not doctors. So be careful of what you learn, except if you're listening to me and Dr. Doug and some of these other credible people giving advice. But I really appreciate you bringing that up. That's a very good point.
Yeah, thanks.
Well, thanks for your time again. I know you're very busy changing the world like I am, and I know how hard it is to carve time for stuff like this, so I really appreciate you.
Yeah. Well, thank you. I love your platform. I hope everybody listening learned something about bone health today. And if you haven't been screened, please get screened.
Please get screened. All right. Thank you.